Afternoon and welcome to day 2 of MS Connect. My name is Tanya Briones and I am the Vice President Community with the MS Society and your moderator for today's session. I'm coming to you from Vancouver and so pleased to join all of you from coast to coast. As we move into our presentations this afternoon, I would personally like to thank each and every one of you for investing your time into learning more about MS and MS research. We are extremely proud of this event and the opportunity that it brings to bring world-class researchers to you to share their knowledge, research, and discoveries. But most importantly, this conference is truly about connecting you to research and researchers, to community experts and vendors, and to other people impacted and or affected by MS. We would like to say a special thank you to our sponsors for making this conference possible. Thank you to our lead sponsor, Roche Canada, and contributing sponsors, Biogen Canada, Bristol Myers Squibb, EMD Serono Canada, Novartis Pharmaceuticals Canada, Pendopharm, and Sanofi Genzyme for providing the financial support needed to connect you, our MS community, to world-class research that continues to push forward discoveries to positively impact the lives of Canadians affected by MS. Before I introduce our speakers today, allow me to give you a few housekeeping details. First, questions can be typed into the question box at any time throughout the session. Also, we encourage you to join the online conversation and share your favorite moments from today's session by posting on Twitter using the hashtag MSConnect. Make your voice heard and respond to our daily poll on our Twitter page at MS Society Canada. And this session is being recorded and will be shared at msconnect.ca. So now into the presentations. The MS Society is proud to present this afternoon's research session with Dr. Michelle Ploughman and Dr. Wee Young. I am thrilled to introduce our speakers. Dr. Michelle Ploughman, who will speak to promoting neuroplasticity and restoration of function in MS, and Dr. Wee Young, who will present on exercise is good for brain health and repair of brain lesions. Dr. Wee Young is a professor and neuroscientist at the University of Calgary, who co-leads the multiple sclerosis neuro team at the university and directs the provincial Alberta MS network. Dr. Young's research has been supported in part by the MS Society of Canada. Dr. Michelle Ploughman is a physiotherapist, neuroscientist, and Canada Research Chair who designs innovative exercise-based treatments to help repair and protect the brain. Her research has also been supported in part by the MS Society of Canada. Welcome, Dr. Young and Dr. Ploughman.
Good day. Thank you for joining me today. My presentation is a more forward-looking one, discussing the repair of lesions and the potential restoration of functions in MS. To do that, we'll need to review some of the major players involved in the MS pathology process. Here we are looking into the brain and the spinal cord, collectively called the central nervous system. We have within our brain and spinal cord billions of these nerve cells or neurons, and this schematic shows one connecting with the other. A signal is passed down this first nerve cell to interact with this second neuron and then to the rest of the body. Some of these axons or nerve fibers are very long, so we need mechanisms to speed up the transmission of the signal, and this is enabled by these wrappings that are called myelin around axons. Myelin is formed by a cell type called the oligodendrocyte. In MS pathology, we have loss of nerve cells, we have loss of neurons, we have loss of this myelin, we have loss of oligodendrocytes. Essentially, many of these are damaged, and so therefore symptoms arise. Here in the bloodstream are circulating immune cells. They are normally very important to protect us against infection, but they're normally kept out of the brain and spinal cord by this barrier called the blood-brain barrier. In MS, some varieties of immune cells become dysfunctional. They gain the capacity to cross the blood-brain barrier to enter into the brain and spinal cord to produce the injury. So that's the a reminder of the key players in MS. Would I move on now to a reminder in this schematic of what is the normal situation of a nerve cell, an oligodendrocyte with a myelin wrapping, that in MS, the oligodendrocyte is lost, and therefore the myelin is gone. And over time, this neuron will also undergo degeneration. The oligodendrocytes and myelin can regenerate in this phenomenon called remyelination. And essentially then we would like to be able to repopulate this, replenish this oligodendrocyte and enable it to reform the myelin to reconstitute the lost connection. Here's another example of remyelination. Now looking at a fiber tract where each of these are axons on nerve fibers coming out at you at right angle. And this diagram depicts the wrapping the myelin around each of these axons. In MS, the myelin is lost, but remyelination can occur where the myelin is now restored around these axons. And this is our goal, to try to promote remyelination in order to restore function. Remyelination is functional. In experimental models, such as in animals that have undergone, in this example, demyelination of the optic nerve, where these animals lose the ability to see and cannot respond to a Menis reflex. Upon remyelination, these animals recovered vision and can now respond to the Menis reflex. Remyelination is enabled by oligodendrocytes, the cell that make myelin in the first place. And the good news is that these oligodendrocytes are somewhat preserved in the brains of people living with MS. So here are examples of these oligodendrocytes preserved. Here's a zoomed up image showing one oligodendrocyte with the many myelin segments that it forms. So because we have some preservation of oligodendrocytes, remyelination occurs in MS. And this diagram shows that repair occurs even in the midst of demyelination. Here's a brain specimen. Here is a remyelinated area in the midst of a lesion that is undergoing degeneration. The point is, remyelination occurs in MS. Remyelination can be detected by a number of means, one of which is the use of positron emission tomography, or PET. This looks at activity within the brain, and in these images of PET scans, at two different time points in one individual, in a second individual, this allows the researchers to look at the repair of myelin in an individual living with MS. And this group from France has documented that in individuals with high capacity of remyelination, where the index of dynamic remyelination is high, these individuals tend to have low disability EDSS score. I think this speaks to remyelination, perhaps recovering some functions, or remyelination preventing the loss of axons and therefore the progression of disability. And indeed, one of the main outcomes of remyelination is the protection of the underlying denuded axons. So in this schematic, when oligodendrocyte is lost and demyelination has occurred, upon remyelination, the underlying neuron and axon is preserved, whereas if remyelination does not occur, the underlying neuron and axon undergo degeneration. So this is a realistic goal in multiple sclerosis, to promote remyelination to prevent the loss of the nerve fibers that give rise to progression of disability. and in the best case scenario, to have remyelination promote the recovery of functions. Through a lot of studies now, we now know that remyelination in MS is indeed quite common early in the disease course, that it varies across individuals. Some are good remyelinators, some are not. We don't know the reason for that. Could be due to genetics, and that is being investigated at this point. But with longevity of MS and with aging, remyelination is reduced. And we also know particularly from preclinical studies, that remyelination can recover function and reduce disability. So a pertinent question to ask is whether the current MS medications that you may use can promote remyelination. As you know, these medications are referred to as DMTs, or disease-modifying therapies. They are aimed at controlling the immune system in MS, and the data shows that they may not directly promote remyelination. However, by preventing the immune attack, these medications may enable the spontaneous remyelination to occur more readily. Therefore, these medications are useful not only to control the aberrant immune system, but hopefully to provide the brain environment now in a position to facilitate repair. However, we need medications aimed at directly promoting remyelination. And in this regard, this is a large area of research in MS these days, the identification of remyelination therapies. This review is by two former trainees, now staff at the University of Alberta and University of Calgary. And what they describe here is that there are a number of medications that are either in the preclinical stage or in early clinical development to try to promote remyelination in MS. So this is a very active field. This is the next frontier. That said, there's still many challenges to overcome for remyelination in MS. We have schematized here a spinal cord. Here are the axons, or the nerve fibers, and the sausage-like wrapping of myelin. Here we have depicted a lesion that has formed, and within this lesion, there are many inhibitors that become expressed, and these inhibitors will need to be overcome in order for successful remyelination to occur. And of course, the axons, the nerve fibers, have to be receptive to the regenerating myelin. We also need to mobilize oligodendrocytes, and some of these are research that have been done in my laboratory. But we want to ask, in addition to medications, can lifestyle factors promote remyelination? And in particular, can exercise promote remyelination? And indeed, there is now a fair body of literature that in people with MS, clinical trial data shows that exercise benefits the brain. So in these human trials, some of the results show that exercise increases cortical excitability and restore normal brain activity, that exercise decreases what is called corticospinal silent periods, so generating more activity within the brain. This is the work of my colleague, Dr. Michelle Ploughman, the other speaker in this series, out of Memorial University. Exercise also decreases lesion burden, decreases the loss of brain volume in the brain of people living with MS. So in clinical trial data sets, exercise benefits the brain. How does exercise benefit the brain? Here is a schematic of some of the mechanisms as derived, particularly from preclinical studies, that the exercising muscle releases a number of molecules that are collectively called myokines. Some of these are shown here, that these then travel in the bloodstream, they cross the blood-brain barrier and enter into the brain to facilitate these beneficial aspects of neurogenesis, new neurons, improving cognition, sleep, mood, and the like. And there is also a literature now showing that other organs are also engaged following exercise. So for instance, the liver also produces a number of molecules that also travel in the bloodstream to cross the blood-brain barrier to facilitate brain well-being. So these are some of the mechanisms that we are beginning to understand. But we have gone on to ask whether exercise can indeed promote the repair of lesions. And here's an experimental study that my lab conducted using a model that involves the injection of a toxin into the mouse spinal cord. We apologize for the use of animals in research, but they are a necessary step to establish some concepts. So in this particular model of injury to the spinal cord, we can monitor over time the recovery of the myelin, shown here in green. The experiments involve mice that are subjected to demyelination of the spinal cord, where after injury, the mice are returned to their cages for recovery. But more importantly, these mice are allowed to exercise by having free access to a running wheel that is in the cage. The controls are demyelinated, but mice that are not allowed to exercise because the running wheel is locked. So we're looking then at the impact of exercise and having free access to exercise from immediately after demyelination. And what we find is that over time, in exercising mice, the number of oligodendrocytes, and here we're looking into the lesion itself, each of these green dots are oligodendrocytes. And what we are able to find is that these increase in numbers in the spinal cord of mice that are allowed to exercise. So exercise increases the cells that are needed to initiate the process of myelin reformation. And indeed, when we went on to look at what are called electron micrographs, fine details of the spinal cord, we find that in demyelinated animals where many of the axons remain demyelinated, as depicted by these purple colors, the axons in animals that are allowed to exercise have myelin around them, and here we have depicted them in this light green color. We have quantitated this to show that exercise increases the number of remyelinated axons. This is the work of Dr. Sam Jensen, who has since graduated. Ongoing work looks at the proteins that are changed within the spinal cord of exercising mice. So here we have again our injury, following which animals are allowed to exercise or do not. Sometime later, we take the spinal cord and subject to protein analysis. And this just shows the runs on a per day basis by these exercising mice. And what I'm trying to emphasize here is that 4 days after demyelination, animals are taken and then their spinal cords analyzed. So this is therefore soon after the demyelination event. What we are able to document is that exercise increases 86 proteins in the spinal cord when compared to those mice that are not allowed to exercise, and exercise also decreases 85 other proteins. So in essence, 4 days after demyelination in exercising mice, a large number of proteins are changed in the spinal cord. No wonder then that exercise improves the well-being of the central nervous system. This is work that is done by current PhD student Brian Lozinski. So some next steps going forward then is to combine exercise with medication. And we have termed this medexercise, the combination of medication plus exercise, in order to enhance the degree of repopulation of oligodendrocytes and repair of myelin. This work is being done by a graduate student, Emily, and a postdoctoral fellow, Dr. Gobani. As well, we are trying to bring in grant funding in order to test this concept of exercise in people living with MS. We have already constituted a team in Calgary, in Saskatoon with Drs. Knox and Donkers, in Toronto with Dr. Ye, at St. John's with Dr. Ploughman, in order to hopefully bring in funding to test this concept of medication plus exercise in people living with multiple sclerosis. So a final slide then, an overview, is that exercise benefits the brain in MS. I've already shown you this segment here of the improvement in the human brain, but this is to emphasize that there is a large body of results from animal models where we have shown that exercise improves remyelination. Others have shown that exercise improves the flavor of the immune response, switches that to reparative inflammation to help with the repair process, and there are other mechanisms such as the elevation of growth factors that are all involved in exercise-induced well-being. Actually, a couple more slides. This year, a consensus statement was published by an expert group constituted by the National MS Society of the United States. Dr. Lara Pilotti from the University of Ottawa is a member of this expert group. And what they are recommending is that for people living with MS, for general well-being, there should be at least 150 minutes per week of physical activity or exercise. We do not know how much more exercise is needed for repair of the brain, but this is a step in the right direction. So the overall summary then is that remyelination occurs in MS. It can be promoted. Discovering repair medications is an active research area with now early phase clinical trials that a lifestyle factor exercise confers benefit to the brain, including the repair of myelin, remyelination. And with that, I urge you to remain active and all the best in your daily lives. Thank you.
Hi, thank you very much for inviting me to talk today about the work that's going on in our lab, promoting neuroplasticity and restoration of function in multiple sclerosis. And if you'd like to comment or drop a note to me, I have my email here, and I also have my Twitter tag at Ploughman. So what I hope to cover today is to recognize some lessons learned from stroke rehabilitation that could potentially be applied in MS. I'd like to present some novel methods to increase rehabilitation intensity without excessive fatigue, discuss interventions that promote neuroplasticity and restore function in MS, and talk to you about what we're doing next in our laboratory. So first of all, let's all get on the same page. What is rehabilitation? And you think, well, everybody knows what that means. But It's a multidisciplinary, coordinated effort to maximize recovery or minimize the impact of injury or disease. So really, rehabilitation has two sides to the coin. The recovery approach means that we aim to restore function, return you to as close to your previous level of function as possible. Whereas to minimize the impact really means compensate. So learning a new method to function. For example, if you had a drop foot and you needed a splint on your leg, a restorative approach might work to increase the strength of the muscles that lift your foot. Whereas a compensatory approach might try a splint or some other technique like a cane, so that you'd be able to lift your leg through while you walk and not scuff the floor. So there's these two aspects of rehabilitation, and the other aspect is maintenance of gain. So after rehabilitation, it's important that when we look at you again in a month or 2 months or 3 months, that the maintenance, what you've achieved, is maintained months later. So there's some 3 key lessons that we've learned about neuroplasticity and how the brain can alter as a result of rehabilitation. The first lesson is there are critical biological events that drive recovery and neuroplasticity. What do I mean by this? I mean that when you move and when you practice, the brain networks that support that get stronger and stronger. So in this way, practice makes permanent. That there are proteins that are released in your brain to support that network change. So we know this happens. The other lesson we've learned is that there's requirement for a high dosage of task-specific training. Well, it means that if you want to relearn something and if your brain becomes plastic and lays down that network, you need to practice that task thousands of times. So if you were, for example, try to learn to play the violin, you would need to practice your scales thousands of times to be able to actually learn that. And that becomes important after a neurological damage or damage to the brain or central nervous system, because we use some of these same networks to relearn the tasks that were lost. The third lesson we've learned in stroke rehabilitation is combining interventions to drive plasticity. And the two things that are really on the current, the latest wave of research is using drugs. So drugs that promote neuroplasticity, combining that with physical therapy or occupational therapy. And the other technique is brain stimulation. So using a special non-invasive coil to stimulate the surface of the brain, activating networks and pairing that with rehabilitation. So we're learning that when we put 2 together, sometimes 2 is better than 1. And I did some of this work in stroke. So the top panel is some of the techniques I used as a physiotherapist, because I worked as a physiotherapist for over 30 years, actually, and part of that time in an inpatient stroke rehabilitation unit, also an MS clinic, and outpatient rehabilitation. And one of the techniques I used was to do a brief bout of aerobic exercise before learning a complex task. And this was really important for people with stroke who had weakness in their hands. And what I noticed is that when I preceded the learning of the task with aerobic exercise, the person was more alert, they did better, they were able to attend to the task, and the arm recovered better. In my PhD work, I actually tested this in an animal model of stroke, and we did the exact same thing. So I paired aerobic exercise on a wheel, just like you see on a hamster and a running wheel. The animal then did upper extremity reaching that I developed a way to make the task more and more difficult. So just like in humans, I did the same thing in animals. But the thing in animals is that you can take the brain out and you can have a look at how the brain has been altered. So looking at that neuroplasticity change. And what we found when we combined the 2 treatments together was that, and this is the, this figure shows you on the upright bar, you'll see reaching performance, and on the bottom is each week. So there was 5 weeks of therapy, 3 times a week. And so animals that received the running and the reaching in red had more robust improvements. Not only that, They had increases in some of these proteins that I was telling you support neuroplasticity, and they had changes in the axons and synapses within the brain. So we've since tried this in a trial where we had four groups of people with chronic stroke, 15 people per group, and they were randomly assigned to the 4 different groups. 2 of the groups received aerobic training. We used the body weight support system. I'll talk about that a little bit more later in regards to MS. But what it is a harness that's supported above the person's head over a treadmill, and it makes sure that the person has no fear of falling. You won't fall when using this harness. And we're able to increase the intensity without feeling the fear of walking. So it's a high volume of walking practice. So 2 groups received that. And the other 2 groups received functional tasks like you would receive in physiotherapy, like balancing on one foot, stepping, practicing walking, walking backwards, turning around. So very important also tasks for the leg, but it was at a lower intensity. And we thought about this pairing idea. Well, what about if we paired this aerobic training with something that all the patients had? They all had problems with cognition. So they told us that they don't feel, since their stroke, that they're able to think quick enough, be able to handle complex information. So some patients received the dual and back cognitive training, which was a specialized online training that was developed at Dalhousie University. And some groups received games. So this is just the Tetris game, like you can load it, but it's very simple. It didn't get more complex over time. So some groups received aerobic training and the dual and back cognitive training, aerobic training and games. Some had activity and dual and back, and activity and games. And so they did this 40 minutes each, paired together 3 times a week for 10 weeks. And then we assessed them again at follow-up to see which groups did the best and had sustained improvements in their cognitive function. And what we found, just like we found in the animal models, that the group that received both things together, the higher intensity aerobic training and the cognitive training, they're the ones that had about a 50% improvement in executive function. What's executive function? That's your ability to think and reason at the highest level that you can. And in our image here, it's the group in the red. It's interesting to note that the group receiving just simple games and doing activity got worse over a period of time. So the 2 groups that did the best were the aerobic and cognitive training group and the activity and cognitive training group. But combining the 2 together was more robust. So, okay, that's stroke. And you say, well, MS is a totally different disease. Maybe these things don't apply. Well, perhaps they don't. But maybe we can start to rethink a little bit about what we're doing in MS rehabilitation. So in stroke, the thinking is towards a restorative approach. Patients are admitted to hospital after they've had their stroke. They receive repetitive, intense practice of lost skills beginning as early as possible to drive this neuroplasticity. The similar types of rehabilitation don't really happen yet in multiple sclerosis. People with multiple sclerosis are often take a more compensatory side. So therapists tend to focus on learning new ways to walk, to transfer, to go to the toilet. They encourage physical activity to prevent functional decline, but not necessarily to restore function. So I'm wondering in our work, and we said, well, can't we think towards restoration? But the problem is that the research in this field is very sparse. And this is a graph that I made several years ago, but it shows you the publications in exercise and rehabilitation in the field of both multiple sclerosis and stroke. So on the upright axis, you'll see the number of publications, and on the bottom are the years. And multiple sclerosis is the solid line, whereas stroke is the dashed line. And although the research in MS rehabilitation is increasing, as you can see from the solid line, the growth in MS rehab research in the last 20 years has only been about 15% that of stroke. This dearth of science and evidence to guide MS rehab certainly impacts the care that people receive. And we definitely need more innovative approaches. I also point out that around 1995 was the first report of exercise-induced neuroplasticity in an animal model of stroke. Yet, it wasn't until 2009 that we saw a similar report of exercise-induced neuroplasticity in an animal model of MS. So you can see that we're nearly 20 years behind in MS, but I think we're on the right course. This is the study that was published in 2009, and it's an important study because I think it changed our thinking. The study is called Exercise Attenuates the Clinical Synaptic and Dendritic Abnormalities of Experimental Autoimmune Encephalomyelitis. That is a mouthful. What is this? This is EAE. It's an animal model of multiple sclerosis. The animals are injected to cause an autoimmune attack. So they had two groups. One group received the injection to produce the multiple sclerosis symptoms, and the other group of animals didn't receive that. They were control animals. Both groups received weeks of intensive running on their running wheels. Then the experimenters looked at their behavior, so their clinical symptoms, the synaptic signaling within their brains, the branching of neurons in the brain, like I did in my study, the severity of lesions in the brain and spinal cord, and the amount of inflammation. And to make a long story short, what they found was that exercise reduced the severity of motor deficits. So on the upright aspect of this scale, you see the clinical score. So a higher score is worse. And the solid dots is the animal with the EAE animal. And the open dots are the EAE animal, so that's the animal that's been injected with exercise. And you can see that the open circles show that the disease, the first onset of the disease was delayed, as well as it wasn't as severe as the animals that did not receive exercise. So this was really one of our first indicators that potentially exercise could be changing the brain. It could be changing potentially the MS brain, possibly, at least in an animal model. This is a new paper which Dr. Young has been talking about, and he showed that indeed exercise stimulates oligodendrocytes, and these are the important support cells that wrap around the neurons that provide myelin to neurons. So, and not only that, when you combine that with drugs, it potentially was even more potent. So, is it possible that we can use exercise at a high dose with high amount of practice to potentially turn back the clock? Could exercise and rehabilitation be disease modifying? And instead of a person seeing these huge bumps in their severity of their disease and disability, potentially could we blunt that, promote neuroplasticity and repair, and return people back to a previous level of functioning? And this is some of the work that we're very interested in our lab. As a first step, we were interested in fitness. And so we are connected to an MS clinic, and we ask people with MS to volunteer to come to our clinic to be tested using VO2 max. So you wear a mask just like this lady's doing. You sit in a recumbent stepper and you move your arms and legs, and we push you until you can't go anymore. And we measure the amount of oxygen you take in, the carbon dioxide you breathe out, and it gives us a score of your level of fitness. So here's some data on the first 50 or so people that we tested. So on the upright scale is cardiorespiratory fitness, and you can see there's very poor, poor, fair, good, excellent, and superior. And on the bottom, you can see the EDSS score. So EDSS is an indicator. It's a measure done by a neurologist that tells you about the severity of MS. So to give you some indicator, someone who's a 0 doesn't currently have any symptoms of MS, whereas someone who's having a 4 is having some walking problems. A person who is 6 is using some gait aids. And what you see on first blush is that the fitness levels are very low. They're also right across. So even people whose EDSS is 0 have very low level of fitness. And also, it doesn't seem, you wouldn't think, you'd think perhaps, well, if you have less disability and less impact of MS, you're able to exercise more and then you're fitter. But actually, we didn't find that. There were some people who were more disabled, you know, EDSS 4 and even 6, who had quite high levels of fitness. So why is this important? We know this because there's a threshold of fitness. So for you to get your groceries, do your everyday tasks, go up and down the stairs, get a shower, you need a threshold of fitness so that you won't be exhausted. And what we found was that the vast majority of people that we tested from our clinic were below this threshold for independence, just based on their fitness alone. So that's a concern for us. So what does this mean in terms of your brain? So we measured the effects of fitness on the brain, and we do this using a technique called transcranial magnetic stimulation. And you place a coil over the brain, and your body is actually mapped out on the surface of your brain. So around here is your hand area, up here is your leg, and so we can place this coil, stimulate the surface of the brain, and we can look at the motor output using EMG. And so, of course, the faster the traffic travels through the brain tells us about the integrity of the circuits. And so we want good, fast, excitatory activity. Inhibition of activity is not a good thing. When you see low levels of activity, it means that the brain is less flexible, less plastic. And we found that even when you control for age, gender, and EDSS score, cardiorespiratory fitness, lower cardiorespiratory fitness was associated with greater brain inhibition, less capacity for neuroplasticity. That is not good, because if you were to have injury to your brain, it means that your brain is less set up, it's less healthy to be able to rebound from that effect. So based on our research, so we've done quite a lot of research in stroke, like I said, and we're really trying to translate some of those thoughts into MS. So the question is, if I said to you, well, you need to exercise to improve your brain health and to increase your plasticity, most people will say, how much is enough? What do I need to do to increase plasticity and my fitness? We did this in stroke, and we looked at all the work that had been done in animal models and in humans. And we tried to understand frequency, F, the intensity, the time, so how long your bout of exercise you needed to do, the duration in weeks, and the type of exercise. And here's the long and short of this story. How much exercise is enough? It's actually quite a bit. It's 3 to 5 times per week, vigorous intensity, so feeling actually out of breath, at least 30 minutes for more than 8 weeks, and continuous. So really trying to be continuously exercising without stopping if you possibly can do that. But there is emerging evidence for high intensity interval training. So that's where you do bouts of high intensity and then you break high intensity and break usually a minute or 2 of each. The challenge is you say, well, you know, I can't achieve that. People with MS have major barriers to exercise, not the least of which is fatigue, heat sensitivity. So as you exercise, your body gets warm. You're supposed to sweat, and that helps to dissipate some of the heat. And we know people with MS, research shows that many people don't have that normal sweating response, so they get overheated. They may also have problems with their legs, so that when you start to exercise or walk or run, you feel unsteady on your legs as you get tired. So we're testing different ways to approach this. How can we drive higher intensity exercise that will work in the real world in MS? So we tried cooling the room. So we have a body weight support treadmill system or a seated recumbent stepper. We have a cold room where we cool it to 16 degrees Celsius using an air conditioner, and we seal around the windows and doors. So we've tested all the different combinations. And so some of the things we've learned when you actually place EMG, so that's electromyography, on the calf muscle. And so it's a big, powerful muscle in the calf, which really helps you walk faster. As your body temperature, so in people with MS, but not in our control subjects, as the body temperature increases, we see a drop in the strength and the EMG output of that muscle. So it tells us that we need to keep the person with MS cool in order so that they don't get leg fatigue. And cooling the room reduce this post-exercise loss of motor drive. So in normal ambient temperature, or we controlled 20 degrees Celsius, we saw that many people with MS experience decreased strength in their calf muscles. But when we cooled you, you were able to do the exact same amount of intensity of exercise without that fatigue. That's important because that's going to guide us in the way we think about exercise moving forward in the future. So we've been testing this vigorous cool room walking training, and there seems to be some important ingredients. So we first decided to test this in a group of 10 people with MS who volunteered, who all used walking aids, so either 2 canes or a walker. Some people were using a wheeler walker and a scooter, so combinations of gait aids. So we cooled the room to limit fatigue. We did that high training and practice volume 3 times a week for 10 weeks. We tailored it to the individual. So we began where the person was. So if they felt they can only walk 20 steps, that's where they stayed. And each time we progressed and progressed and progressed to get that intensity. It was delivered by physiotherapists, so we focused on the gait quality, the movement of the hip and the knee and the ankle as normal as we could. And we used the body weight support treadmill for safety. So we did this. And I'm just going to show you, these individuals have all agreed to show the video, so I'm going to show you what it looks like. Some people had found it really easy, and other people needed quite a bit of help. And you can see the lady in the middle. She really needs quite a bit of help, but after 10 weeks, she didn't need as much help. And what we found was, and I'll show you in this graph, so on the upright is the distance walked in meters. And there are 2 groups of individuals. So some people used unilateral gait aids, so that's a cane. And in the bottom group, they used bilateral gait aids or power wheelchairs and scooters. So they had more difficulty walking. And what you found is imagine on day 1, everyone started to their maximum. At that point, they said, I cannot take 1 more step. This is where I can walk, and that's it. And what we found was that threshold of what people thought was their maximum gradually went up, and an astounding amount. So, for example, our group who used bilateral gait aids, they only could walk about 250 meters. That's about 1/4 of a kilometer. After 10 weeks, some people could walk a full kilometer. The same way with our single gait aid users, they walked about 1.5 kilometers, and by the end, they could walk over 2 kilometers. So we saw a 50% increase in the distance walked in 40 minutes. What does that mean when we measure? So we're showing you each individual person's score, and this is the time 25-foot walk on the left-hand side. So the faster you do this, the better. So this is your fast walking speed. So you can see the individuals, they started off at baseline, walking anywhere between 4 seconds and 40 seconds to walk 25 feet. And everyone improved. And at follow-up, we start to see a drifting. They're not all the way back up to where they were, as slow as they were, but they're starting to drift back up. We also found that fatigue at baseline, so this is it's a vitality measure. So the higher the amount of vitality, the less fatigue. And you can see at baseline and after, everybody had significant improvements in their vitality. And even though some people dropped off at follow-up, meaning 3 months later, we tested everybody again, it didn't go back down to baseline. So we learned that this 10 weeks of intensive training could turn back the clock, even in individuals who had were really challenged in terms of their walking. So we had significant and sustained improvements in fast walking speed and fatigue. So what did this do to the brain? What we found, like I showed you before with our transcranial magnetic stimulation, we showed that the intensive training shifted the balance towards excitation and away from inhibition in brain circuit. So it shifted that balance and made the brain more plastic. And here on the left-hand panel, I'm showing you the cortical silent period. That is the inhibition. And you can see before, this was the levels before, that the inhibition dropped, but unfortunately at follow-up, their inhibition went back up. And the same way with excitation, so the excitation improved, so when you go down, it's actually better, improved, but then went back up at follow-up. So the message is that, yes, this training can make sustained improvements in walking and fatigue, at least in this small group of individuals. The benefits to the brain are important, but only short term. So it means that when you stop training, it seems like you lose these benefits. So you need to maintain the exercise in order to get the benefits in the brain. So what's next for our recovery and performance lab? How are we proceeding with what we've learned so far? So we're going to do a head-to-head comparison of 2 training methods to determine the effects on balance and walking recovery and brain function. The 2 methods, one will be our high-intensity walking training program, and the other program will involve looking at walking quality, so improving the movement at the hip and knee and ankle. So we're going to take these 2 common approaches that physiotherapists use to figure out which one is going to work the best. We're also preparing to test a new device called PONS, which is a neuromodulation device by stimulating the tongue, and you combine that with walking and balance exercise. I'll be working with Dr. Sarah Donkers at University of Saskatchewan. We're also mapping how fitness impacts epigenomics. And I'm working with neuroimmunologist Dr. Craig Moore, and we're looking at how fitness changes your biology of the immune system and can protect people over time against MS progression. Our work is funded. We would not be able to do this work without the funding of the MS Society of Canada, by the Canada Research Chairs Program, by Canada Foundation for Innovation, and our many partners. We absolutely would not be able to do this without our MS partners, people with MS who volunteer to be involved in our research. And I also can't do this work without the very important students. One of the jobs we do in science is to train the next generation of young scientists who will go on to progress and make better treatments for MS. Thank you.
Thank you so much, Dr. Ploughman and Dr. Young. We are going to move into questions, but just before we do that, I do want to take one moment and just welcome our French-speaking guests. As I understand, there was a slight delay at the start of the session, and I'm very pleased to have you join us today. My name is Tanya Vrionis, and I am the Vice President Community with the MS Society of Canada, and pleased to be your moderator today. So with that, we are going to get right into some questions. So please don't hesitate to type your questions and comments into the box, the question box. And while we wait for those, maybe I'll start with a question or two. Starting with Dr. Ploughman, you've presented some great progress in your research today. How have the current realities of COVID-19 impacted the way you work and this pace of progress?
I think for everyone, it has impacted our lab tremendously. We were right in the middle of our trial of the two walking interventions and had to stop it. And so we're hoping that we will be able to begin that trial soon. It's the kind of thing that you can't do virtually. You really need the support of an experienced therapist to help you. So we're fingers crossed. The MS Society has given us an extension of that time, and we are still ready to go.
Thank you. We do have a question from Karen Tweed in Winnipeg. Would comorbidities contribute to why some people remyelinate better than others? Dr. Young?
Well, we do know that different individuals can remyelinate to different extent, that some are so-called good remyelinators and some not so good. We don't really know the spectrum of reasons for that at this point. One could be genetics, one could be lifestyle, such as level of physical activity, where those who have engaged in high level physical activity might tell us that they fare very much better than those with lower amounts of activity. Or, as the question indicates, other factors such as other comorbid conditions could also be contributing. These are things that are being worked through at this point. How do we get people to be good remyelinators? That's a very good question.
Thank you. Next question from one of my fellow West Coasters, Marilyn Lenzen in North Vancouver. Is there research that shows what type of exercise is best, such as cardio versus strength training?
That's a good question, and it's something that we're actually investigating, and we're really interested in it. And it seems I'll say that you have to, first of all, have muscle contraction. So the muscles need to contract at a high enough amount in order, like Dr. Young was saying, to release BDNF, IGF-1, and all these potential growth proteins. And I think there's value in both aerobic training and strength training. But what we understand is that aerobic training seems to have more robust effects on the central nervous system, and because it increases these neurotrophins, and that it's a vascular exercise, and the brain is highly vascular, and these proteins really need to get to the central nervous system. So I think that aerobic exercise has more robust effects on the brain. But if I were to say to improve walking, strength, power, ability to walk quickly, then strength training is important. It depends on what you want to achieve. I would say training is probably superior in terms of its benefits in the brain, but strength training is in terms of its effects on the body and on preventing frailty and improving walking.
Thank you for that. A viewer would like to know the presenter's thoughts on the significance of massages, and should that be part of their treatment?
Michelle, would you like?
Yeah. I think massage is beneficial. It reduces pain. It could be beneficial for spasticity because, of course, many people with MS have spasticity and their muscles feel tight. If it changes your walking, if it changes your balance, if it changes your brain health, I don't think so. I think you really need to engage in that high intense training that's focused on the task you want to improve. So I think massage makes you feel better. It helps to relax muscles. It helps to reduce pain. Does it actually improve and restore walking or upper extremity function or cognition? I don't think so.
One, we are recognizing that exercise or physical activity not only engages muscles but also many other organs of the body. There's now increasing evidence that a tissue such as the liver is generating important molecules that go on to the brain upon exercise. The gut microbiome is another thing that changes. So I, for one, would be for movement and aerobic movement, as pointed out by Dr. Ploughman early on. The passive massage is useful for certain things, but I would like to see whole bodily movement that involves many of our organ systems.
Thank you for that. Christine from Vancouver starts with a thank you for the information. Does this exercise apply to those with secondary progressive MS?
I think also, I think Dr. Young probably has some thoughts about this as well. We deliberately in our first trial decided to approach people with secondary progressive and primary progressive MS. And we did this because we said, if we can restore walking in this group, then I think it's good foundation and good pilot work to show us that we can probably restore walking in someone who's had a relapse. So I would say yes, there's capacity for recovery and restoration of function. I think that there's probably capacity for remyelination and repair, but I think as you get older, as MS is progressed further, it's more difficult to repair. That's my thinking. But like I said, our study was actually specifically in people with progressive MS, and we showed that it was beneficial to walking, but that once people stopped, they seemed to start to drift back to baseline. And so it's a classic use it or lose it.
And I would be thinking that exercise is not only good for repair or protecting the nerve fibers from further deterioration, but also good for other brain functions such as cognition, whole body physiology, so that I see benefits of exercise across all spectrum of multiple sclerosis.
Great. Thank you for that. This has been fantastic, and I'm afraid that that's all the time that we have for questions today. I'm sure that there's many more to come. A huge thanks to everyone for your attention, and I'm sure that you'll join me in reiterating our gratitude to each of our honored speakers for their very valuable presentations and insights. For those not joining us for the social engagement session, I do hope you can all tune in tomorrow for our session with Dr. Anthony Feinstein on cognitive dysfunction in people living with MS. But just before we shift over to today's social engagement session, and I'll have some housekeeping pieces for you in a moment on that, we would like to share the following video presented by MS Connect lead sponsor Roche Canada.
I was driving from work to come home. I felt like a pop in my head and immediately started feeling like something was draining out of my body. I woke up the next day with a 4-day headache and excruciating pain, and then my vision went dimmer and dimmer. I could not see anything straight in front of me. It's very common for patients with NMOSD to be misdiagnosed because it is very similar to MS. My current symptoms consist of fatigue and body pain. Sometimes it's manageable and sometimes it is just extreme and I can't get out of bed at all. My husband is my rock. He's the one that is just by my side. He's always a step ahead of me. Anything I need, he'll be immediately there. with it in hand, and that does help me. I happened to find a lot of support groups online that helped me. Any question you have, any time of day, there's always someone there willing to answer your question and have someone that understands exactly what you're going through. The biggest impact this diagnosis has had on me is I have had to take 10 steps back. Everything must be much slower, so I've honestly just tried to enjoy life as much as I can.
We are just going to take a very brief break before our social engagement session, but just a reminder, the social engagement session is not happening on this stream. It's a separate Zoom meeting that you will need to join. The link to the Zoom meeting is at the bottom of your screen in the gray area just below the slides. You can join that meeting now on Zoom, and the session will begin in about 10 minutes. Once again, thank you to everyone.